Hello, everyone. Welcome to our free webinar, Induction, Understanding Informed Choice and Methodology. I welcome you guys. Thank you so much for joining me today. And for those of you who are watching the recording, thank you for joining me for that as well. I just want to make sure you guys can all hear me okay. If you cannot hear me, if you just want to type that in the chat real quick, that would be awesome. Actually, maybe let me know if you can hear me. That would probably be better. If someone can just type in the chat, yeah, we can hear you. That would be awesome, just so that I know that audio is working correctly. So, okay, good. Yes, awesome. Thank you guys. That's great. So welcome today. I'm so excited to have everyone. I'm so excited for this webinar. I started doing free webinars at the start of the pandemic just because it seemed like we really needed to be able to connect with people and help people that may be experiencing financial difficulty and not necessarily able to access information that they had to pay for. So I started offering free webinars about once every 6 weeks or so. We've covered a lot of really awesome topics, including physical postpartum recovery, prenatal nutrition, storing or expressing and storing human milk. So lots of really great topics and some other ones too. They're all available on the website. So if you're interested in checking those out, you can. Today we're talking about induction, and I'm really excited for this because I do cover it in my childbirth classes, but I feel like we never have enough time to talk about it in depth. And as you'll see from the statistics, it's something that really does affect a lot of birthing people. So this is a really important topic just to have some information on, to be aware of the research, to be aware of your options. It's a really good topic to have all that info about. And then for those of you that are joining as birth professionals, hopefully this webinar will help you consolidate some information and get an idea as to what the most common reasons for induction are, and how to possibly, without overwhelming clients, share this information with clients in a way that is really usable for them and empowering. You know, it's not about telling people that there is one right or wrong way to do things, because there's not. Instead, it's about helping people gather as much information as they need to make a decision that feels really good to them. So that's what we're going to be talking about today. I'm so excited for it. We are recording, so just keep that in mind in case, you know, videos are going on or, you know, whatever. You can keep your videos off. I don't need you guys to have your videos on, but you're always welcome to turn your videos on if you want to do that too. I would love for everyone, though, who's joining us live to type in the chat where you're from and what your role is. If you're a parent, if you are a doula, if you're a nurse, if you're a midwife, if you're a doctor, whatever, whatever your role is in the community, that would be awesome. So if you want to type in where you live and what your role is in the chat, that'd be great. I think that'll just help people kind of see who's coming from where and maybe even connect with people in their community. So you guys are welcome to type that all in there. Let's see, we're going to use slides today. I know slides are super boring, but this information is kind of research heavy. So it's helpful, I think, to be able to see it in print rather than just hear me talk about it. And as many of you may know, I love to do a lot of movement-based stuff. I do a lot of work with pelvic dynamics. So a lot of times we'll get up and move throughout our workshops and webinars. We're not going to be moving much today. So if you need to be moving while you're listening, that's awesome. Go ahead and do that. Do whatever you need to make sure that this information is as absorbable to you as possible. We will leave a little bit of time at the end of our webinar. I aim to leave maybe 5 to 10 minutes just to cover any questions. So what I would love for you guys to do with questions, just because we do have so many people joining us today, which is awesome. If you can put your questions in the chat, that would be great. And you can type in questions whenever they pop into your head. So don't wait until the end. And then in the last 10 minutes or so of our webinar, I'll go through the chat and just pick and choose some questions that I think might be relevant to as many people as possible. And then we will answer those questions. And if there's anything that you're asking that I don't have the research on off the top of my head, I will include that in the follow-up email. The follow-up email will have the recording to this webinar, which you will have access to forever. So if you are a pregnant person and you're 4 months into your pregnancy, I'm really happy that you're here, and you'll probably find that this information is something you may want to revisit down the road. And for birth professionals, same thing. Sometimes it's really helpful to go back and listen to something again or see that research or see those statistics again. So you'll have access to the recording forever. If you wanted to share this recording with friends or family members or colleagues, you can absolutely do that. You can find the record. You will be able to find the recording on the website for free. It's for free forever. So anyone can access it on there if they did not attend live or sign up, pre-register or sign up on the wait list. So let's go ahead. Oh, well, actually, I should probably just tell you a little bit about myself, just so you know who the heck I am. My name is Brittany Sharp McCollum. I use the pronouns she and her. I own a business called Blossoming Bellies based out of the Philadelphia area. I am coming to you from the Eastern Standard Time Zone. I know we have people coming from all over, so those of you in other time zones may very well be watching the recording, which is great. I am a childbirth educator. I'm a birth doula, I'm a breastfeeding counselor, and I also do pelvic biomechanics education. So that's really where a lot of the passion for this work lies with me, is helping people understand how much autonomy they actually have in birth, and whether they choose to have pain medication or not, how they can utilize movement in all births. So you'll find that a lot of the webinars available on my website are things about pelvic dynamics. I think it's really important information that's often overlooked in a lot of trainings, whether those are doula trainings or childbirth education trainings or midwifery or obstetrical trainings as well. In addition to that, though, my pelvic biomechanics stuff that I do a lot of childbirth education. And like I mentioned earlier, induction is one of those topics that is really important to cover, but sometimes just in the whole scheme of everything that I love to cover in birth classes, we don't always have enough time to give it the attention that it deserves. So I'm happy to have this webinar available to everyone so that they can gather as much information as possible. If you are interested in attending future webinars, I would love to have you. We have a few really awesome ones coming up in the next couple months. Next month, or not next month, like a week and a half from now, maybe 2 weeks from now, March 17th, that would be 2 weeks from now. We have Realistic Expectations in Infant Sleep with guest speaker Marcella DeRosa, who's a certified baby-led sleep specialist. And then in April, we have Body Positive Fitness in the postpartum period with Jessica Brock-Pitts, who is a personal trainer and a certified group fitness instructor. And then in May, I'll be facilitating a webinar on peanut balls for an efficient labor and birth. So you can join us for any or all of those sessions. They all have contact hours associated with them through ICEA. So for birth professionals, you can get contact hours that go towards recertification. For parents, I think this is just going to be really awesome information. And then coming up in April, I have my Creating Space workshop, which is pelvic dynamics, fetal positioning, and use of the rebozo in labor and birth. And this is specifically for birth professionals. So this workshop has 6 CEs associated with it from ACNM. So that's good for midwives, nurses, also childbirth educators and doulas. We have a virtual session coming up Sunday, April 18th, and a live in-person session in South Philadelphia with only a few spots available because of restrictions. So that's coming up Saturday, April 17th. So hopefully you guys can join me for any or all of those awesome things we have coming up in the next few months. So we do have a quick question here. Is the infant sleeping class best taken prior or after birth? I think the infant sleep, the realistic expectations in infant sleep, that webinar is going to be beneficial for someone who is pregnant still or postpartum. I think that there's going to be a lot of information covered there that's good to have up front, but also probably some tips that can be useful for people that are experiencing their postpartum already. So I think you could take that webinar either way. Cool, so let's go ahead and get started. I'm gonna share my screen with you. Today, as you can see here, we are talking about induction. We're covering understanding informed choice and methodology. So this is really going to focus on knowing your options and also knowing what your rights are in terms of consenting or refusing, or what your other options are, and methodology, how the induction process unfolds. So here's just my little disclaimer here. Please remember that the information that's contained in this presentation and in these slides is not medical advice. please employ the evidence-based care process with your medical provider. So this may come up later on in the webinar, but I just want to kind of put out there what evidence-based care is. Evidence-based care is not looking at the research and doing what the research says. It is not taking your provider's recommendation and doing what your provider says. It is a thoughtful process of weighing out for each individual what the research suggests, what your own trusted care provider's recommendation is, and what your own preferences are as well. And we will revisit this. I know at one point when we talk about a large study that was done recently on induction, but this is a really important process. This means that the choice that one person makes may be very different than someone under the same circumstances makes. The individual, the right to individual choice, even when it comes to things like labor and birth interventions is extremely important when we are talking about people feeling like they have a say in the decision-making process. And why is it important for people to feel like they have a say in the decision-making process? Because that's what the research tells us leads to a more positive outlook on their birthing process. And why is it important to have a positive outlook on your birthing process? Because it translates into a more positive postpartum experience. So being involved in decision-making actually affects someone's postpartum experience. It's less about the choices that you make and less about whether things go according to plan, but more about whether or not someone feels like they have been an actively involved part of the decision-making process. And that is what evidence-based care allows for. A look at the research and what it suggests, input from a trusted care provider, and how does this fit into my own preferences, my lifestyle, my belief system. Taking into account those three components is how we access evidence-based care. So the information here in this webinar is research-based. I will probably touch on things related to how people make different decisions, but please remember that one person's decision is not necessarily someone else's decision. This presentation is provided for informational purposes only, and it is intended for both expectant parents and birth professionals. Participants in and observers of this webinar assume all responsibility for their use of this information and any further studies they complete. This is a starting point, right? This is creating the foundation for further exploration. If I touch on a topic today that you're like, oh, that feels like something I've heard a lot more about, let me dive deeper into that. That's awesome. That's what I would love for you to do with this information. Pick and choose what feels really relevant to you or relevant to your clients and use this as a starting point for gathering more information. Please also remember that each birth professional has a scope of practice within which they work. This means that doulas and childbirth educators do not make recommendations or diagnose scenarios. They provide research, they connect people to resources, they help people sort through all of their options, but doulas and childbirth educators do not tell people what to do. Also, I ask that you don't reproduce or share these slides in any way. But again, if anyone is interested in accessing this information, they can absolutely find the recording later on today on the website for free, available to everyone. So again, thank you guys so much for being here today. So our objectives today are to define induction versus augmentation. Quite often the term induction is used to kind of cover both inducing and augmenting labors, but we're going to kind of pick them apart and see how they're slightly different from one another. We're also going to recognize common acute, clinical, and then also non-urgent reasons for induction. Acute clinical reasons for induction are reasons for induction where something is happening right now. There is some sort of specific red flag that has come up at this moment. A non-urgent reason for induction is something more like, well, the research shows that in this scenario, this can be more likely, although the health of the birthing person and the baby are fine right now. That would be a non-urgent reason for induction. So we're going to go through some of those common acute clinical reasons and non-urgent reasons for induction. We're also going to develop awareness of the active role that clients have in decision-making. This goes back to what we were talking about, being an active participant in the decision-making process and how important that is. And then we're going to kind of dive into the meat of this by differentiating between different methods of induction and augmentation. We're going to do this in terms of administration, progression, and risk. So we're going to look at these different options for induction and augmentation, and we're really going to focus on them in terms of what does the administration of this look like, what is the expected progression of use of this intervention, and what are the risks and or benefits associated with these different methods of induction. So let's dive in. So first we have to figure out what the difference is between induction and augmentation. Again, I think that the term induction is used kind of as a catch-all. People talk about being induced. People say, well, I was in labor and then I had to be induced. Well, let's break that down and see what that really means. So induction is the process of initiating labor when the process is not occurring spontaneously. Someone is not in labor, and it's been decided, ideally, between them and their provider, that it seems like the best choice is to get labor started. That's induction. Augmentation is the process. If you guys can just make sure your
stop fucking using it.
I hear somebody's mic on. So if you can just double check that your mics are off, only because that way we have less background noise. Cool. Thanks, guys. Augmentation is this. The process of increasing frequency, intensity, and duration of contractions that are already occurring, whether that is due to an induction or spontaneous labor. So with augmentation, there are already contractions happening, and we need to make them, quote unquote, need to, depending on the circumstances, need to make them more frequent, more intense, or longer. That's augmentation. So augmentation, there are already things happening. There's already a fairly consistent labor process happening, or maybe there was and things kind of petered out, or we're undergoing an induction process and the induction process itself needs to be augmented. Induction means nothing consistent is going on and it's been decided between you and a provider, between the client and the provider, that it's best to get things going. So here are some stats with induction. And again, like statistics in our country, and I know there's a few people joining us from other countries, particularly we have some people joining us from the UK, and you guys have really awesome standardized reporting. So that means that you have really awesome, accurate statistics. We don't. In the US, we do not have standardized reporting from state to state or from hospital to hospital, which means a lot of our statistics are actually based on research studies, which are not necessarily reflecting accurately what's happening on a national level. So please take these statistics with a grain of salt, because they are not the best statistics out there, because our standardized reporting doesn't even exist. So here's the thing with induction. It can be elective, meaning there's not a medical or clinical reason to induce. A person has just decided with their provider that they would prefer to start the induction process. That's considered an elective induction. Or induction could be clinically indicated, meaning that there is a concern about either the parental or fetal well-being. So it can be decided that we need to get the labor process going because either there's a red flag that has come up with a pregnant person, or there's a red flag that has come up with the baby. So we have elective inductions, and then we also have medical or clinically indicated inductions. Now, according to statistics from the CDC, which again, these are not necessarily accurate national statistics, 23% of singleton births were induced in 2012. So singleton means someone who's pregnant with one baby as opposed to having twins or triplets. So the CDC says in 2012, which is the last year that they have that they have statistics on their website for induction. In 2012, 23% of people with singletons were induced. Now, there was this survey that came out in 2013 called the Listening to Mothers Survey 3. So it was their third survey, Listening to Mothers. That's what the survey was called. And according to the Listening to Mothers survey, 41% of people were induced. 41% of people who responded to this survey were induced. Now, that's a significantly higher number than just 1 year before what was reported by the CDC. So here we have a pretty significant discrepancy in statistics. Now, keep in mind that a survey is somewhat self-selective, so there are some concerns with a survey being, what we're using for statistics, but we also have really crappy reporting state to state and hospital to hospital. So we can't necessarily say that the CDC's statistic is accurate either. I think what's important to focus on here is that there seems to be a big discrepancy. And if you'd like, if you have an idea as to what the induction rates are in your area, you're welcome to put that in the chat right now so that people can check that out too. In the Philadelphia area, I do not have a specific statistic, but it does seem that induction is happening far more frequently than 23%. But that is completely anecdotal. That is completely not research-based. That is me saying in the Philadelphia area, this is what seems to be happening. But there's a big discrepancy, and that's what I want you to focus on, this discrepancy here with the reporting. Now, in 2018, there was research that came out that suggested, and again, this is research, this is not a statistic that was nationally reported, research that said about 27% of people are induced. What we do know is that the number of induction, or the rate of induction for all gestational groups, so that means whether someone is 38 weeks, 39 weeks, 40 weeks, 41 weeks, 42 weeks, for all gestational age groups, the rate of induction in 2010 was at least twice as high as it was in 1990. That's a really interesting number, right? To say that within this 20-year period, we doubled the numbers of people that were being induced. That's an interesting statistic that we won't dive into more today, but if that sparks your interest, I encourage you to do a little bit more digging about that. So those are some induction statistics. Now, if induction statistics are challenging to get, augmentation statistics are even harder to get. We literally do not have any statistics on augmentation of labor that are standardized across the board countrywide. What we do see in terms of research on augmentation is that it varies significantly from place to place of birth. We have some places where it is suggested that only about 15% or so of labors are augmented. I'm just going to remind you guys, if you can just turn your mics off, that'd be great, just so that there's less background noise. I think somebody's mic is still on, if you don't mind just turning it off. You can just turn your mics off, that'd be great. Only because, let me see if I can maybe do that. Here, there we go. Okay, I think I did it. There we go. Okay, sorry. I was able to set it so that the mics stay off, only because we hear background noise then and it's harder to hear the information. So what were we saying? So yeah, we have some research that shows that augmentation rates can be as low as 15% in some hospitals. And we have research that shows that augmentation rates are as high as about 85 to 90% in some hospitals. From what I have gathered from talking with nurses in hospitals in the Philadelphia area, they suggest, and this again is not research, this is anecdotal, this is through conversations I've had with providers at hospitals in the Philadelphia area. A lot of the hospitals suggest that their augmentation / induction rates, so if we kind of group them all together, are as high as about 85% for people birthing in hospitals in the Philadelphia area. That's not an official statistic, that is through conversations I've had with nurses. But whether that statistic is off by 10 percentage points or what, that's a significant number of people that are either being induced or augmented in labor. But again, we just don't have those great national statistics that would make it a lot easier to hone in on what's happening here. So the difference between induction and augmentation. Induction, there's no labor happening. It's been decided that it's best to get labor going. Augmentation, there is labor happening, whether it's spontaneous or induced, and it's decided that we need to strengthen, lengthen, intensify these contractions. So let's take a look now at the most common reasons for induction. So we have at the top some non-urgent clinical reasons. So these are clinical reasons, but they're not like, yeah, we need to do this right now because there's a red flag that's come up. And then at the bottom, we have acute clinical reasons. We are not going to dive into each of the reasons in depth, but I do want to point out that I listed out the non-urgent clinical reasons in order from most common to least common. Going post dates is the most common reason for people being induced. And this is a non-urgent clinical reason, meaning that simply going post dates, and I'll define what that is in a minute, does not mean that in that specific pregnancy, there's a red flag that comes up. It means that based on the information that we have from studies, it's been decided, ideally between the client and the provider, that they feel most comfortable in weighing out risk versus benefit in getting labor started rather than waiting for labor to spontaneously begin. It does not mean that a red flag has come up for that individual person in their pregnancy. So there is the difference between post dates and post term. So I want to mention what that is. Post dates means being past the due date. The due date is just an average of 40 weeks from the time of the start of the last menstrual period. What research shows us in terms of averages in giving birth, we see that about 2/3 of people give birth within 10 days of their due date, one direction or another. We see that on average, first-time birthing people go into labor about 5 days past their due date. And we see that people giving birth for the second time tend to go into labor 3 days past their due date. So we do see that 2/3, a significant number of people, go into labor within a 20-day window, a 20-day window, 10 days on one end or the other end of their due date. And we see research suggests that only about 3 to 5% of people actually give birth on their due date, which is 40 weeks from the start of their last menstrual period. So going post dates means going past the due date. Post term means going to 42 weeks or later. So post dates is going past the due date. Post term is going past 42 weeks. Now, according to the Listening to Mothers Survey 3, which I mentioned earlier, about 44% of induced labors were due to being full term or close to the due date. So we said about 41% of people in that survey said that they were induced. Of that 41%, roughly 44% were induced because they were either full term or close to their due date. Of that 41% of people that reported that they were induced in the Listening to Mothers Survey 3, 18% said that they were induced for being quote unquote overdue, which is defined as being past their due date in the context of that survey. So 44% of people were induced because they were full term and close to their due date, not necessarily having reached their due date. And 18% of those inductions, of that 41% of inductions, were due to labors being, or due to people being overdue, past their due date. And overdue is not a technical term. Overdue is the term that was used in that specific survey. And again, that comes from DeClercq et al., but that is the Listening to Mothers Survey 3. That is the most common reason for induction, going post dates. Now, another common reason for induction that is a non-urgent clinical reason is PROM, which is premature rupturing of the membranes. PROM in a full-term pregnancy is a different scenario than PROM in a preterm pregnancy. So if the water breaks before contractions start and you're full term, the research suggests different pathways than if the water breaks first and someone is preterm. I would suggest checking out the evidence-based birth article on PROM and induction for PROM because it has a lot of really fantastic information and it talks about the different pathways that people can take. And in a low-risk pregnancy that is full term, that experiences PROM, premature rupturing of the membranes or breaking of the water before labor begins, what the research actually suggests is that it is reasonable to induce, and it is also reasonable to wait up to 3 days for labor to begin spontaneously on its own with intermittent monitoring of the baby by the provider. And this does not necessarily mean being in a hospital being monitored. It means possibly going back and forth or having a provider that is willing to come to the home and do monitoring. So PROM with a full-term pregnancy is a different scenario than PROM with a preterm pregnancy. Premature rupturing of the membranes full term happens about 10% of the time or so. So fairly significant enough that it's definitely worth talking about. And again, a non-urgent clinical reason for induction. Concern about the size of the baby is the next on the list here. This means that a provider is thinking the baby may be too small, intrauterine growth restriction, or thinking that the baby may be too big. Babies being too, quote unquote, too big is a diagnosis that happens more commonly than the diagnosis of intrauterine growth restriction, which would be a baby that is too small for gestational age. But according to research, and again, Evidence-Based Birth has a really awesome article on this too. According to research, the diagnosis of a big baby in pregnancy has a greater impact on the laboring process than whether or not the baby actually is big. So I'll say that again, because that can kind of be like a little tricky to wrap your head around. The diagnosis of a big baby in pregnancy has a greater impact on the birth process than whether the baby is actually big. So, and the weight for a big baby, I think, is 8 pounds, 13 ounces. If a baby is that big or larger, then it's considered a big baby. But here's the thing, the fallacy is that we don't have an accurate way of predicting the baby's weight in pregnancy. Ultrasound has about a 50-50 chance of being accurate in terms of estimating the size of the baby. And same thing with palpation of the belly. So some providers prefer to palpate the belly to get an idea as to what the size of the baby is. Research actually suggests that palpating the belly is just as inaccurate as using ultrasound in the 3rd trimester to determine the size of the baby. And then we come to our last non-urgent clinical reason, and this is the ARRIVE trial. I'm sure for those of you that are birth professionals, you are probably somewhat familiar with the ARRIVE trial. There is a lot of information online about the ARRIVE trial, and there are 2 great analyses of the ARRIVE trial. One is by Hensie Gore. Her last name is spelled G-O-E-R, if you wanted to search out her analysis. And then Rebecca Decker of Evidence-Based Birth has a good analysis of the ARRIVE trial as well. The ARRIVE trial looked at elective 39-week induction, and what they were focusing on was if electively inducing at 39 weeks, so without medical reason, inducing simply because someone was 39 weeks pregnant, if that affected fetal well-being and cesarean rates. And what they found is that elective 39-week induction had no change, good or bad, in fetal outcomes, and it actually showed a lower cesarean rate than people who were induced later on. So based on this research, and I'm going to read this to you, I know this is lengthy, but ACOG concludes that it is reasonable to offer elective induction to low-risk first-time parents at 39 weeks of pregnancy. But they urge care providers to first consider 3 important factors: the values and preferences of the pregnant person, the available resources to assist longer labors, and the birthplace's protocol for quote unquote failed induction. ACOG does not recommend elective induction at 39 weeks of pregnancy. They state that it is reasonable to offer this, but particularly these 3 things need to be taken into consideration. Let me explain what it would mean to take into consideration the values or preferences of the pregnant person. 39-week elective induction means that the person is undergoing the induction process. If a low intervention birth is important to the person that is giving birth, then an elective induction is not a low intervention experience. It is a higher intervention experience. So people who are seeking out a low intervention experience would not necessarily have their preferences match up with this choice. Let's look at the other thing, the other reason, having resources available to assist longer labors. Here's the thing with the ARRIVE study. The participants, the providers that were participating in the ARRIVE study, knew what they were trying to achieve with outcomes. If a provider is part of a study and knows that they are trying to look at whether elective induction increases or decreases cesarean rates, they may be more likely to give people undergoing an induction a much longer period of time to allow that induction to unfold and progress than they would be if they were not part of that study. So there's a little bit of potential bias within that study. If a place of birth and a provider do have the resources to assist long inductions, then perhaps the ARRIVE trial research would apply to that scenario. But if they do not have the resources to support a longer induction, then perhaps they would not be able to mimic the results of the ARRIVE trial in their particular birthplace. And this kind of ties into the protocol for failed induction. So failed induction is when it's decided by a provider that the induction process is not working and therefore a cesarean birth needs to occur. The protocol for failed induction at this point is recommended by ACOG to be 24 hours of Pitocin given, the bag of waters being broken, and 6 hours without cervical change. That's in an induction process what ACOG, which is the American College of Obstetricians and Gynecologists, says would be a potentially failed induction. So is this what each hospital and each provider is allowing to happen before deciding that this induction has not worked? Or is somebody at the point now where they are not yet in active labor, they're 3 centimeters, they've been laboring for a long time, they do or do not have Pitocin, and it's been decided that by a provider that in fact, it's time to call this induction failed. If they have not reached that 6 centimeter mark with, and I don't think I mentioned that before, I'm sorry, but if they have not reached that 6 centimeter mark, they have not had 24 hours of Pitocin, they have not had their bag of waters break spontaneously or by a provider, they have not had 6 hours without cervical change, then that does not fit into the protocol of failed induction by ACOG. Let me also tell you this though, that someone who's undergoing an induction process where they've been induced and now gotten to the point where they are 6 centimeters and they've had 24 hours of Pitocin and their water's broken and they've had 6 hours without change, that's exhausting. That's exhausting. So although that is ACOG's recommendation for calling an induction failed, that does not necessarily mean that that's going to sit well with the preferences of every laboring person. You always have options. People have the option of saying, I am done with this. I would prefer to move forward with a cesarean birth now. But in terms of what ACOG is saying, not necessarily taking into account personal preference, this is how they would suggest to providers that they call an induction failed, quote unquote failed, which I hate using that word to discuss birth. There's never failure in birth, no matter how a baby is born. There's no failure in birth at all. But anyway, this is the term given. And now let's take a look at what ACNM says. So ACNM is the American College of Nurse Midwives. Their response to the ARRIVE trial is that ACNM continues to promote normal, healthy physiologic birth and a person's right to make decisions during pregnancy. They propose that costs might be better spent on less invasive approaches to reduce cesareans, such as continuous labor support from a doula. So they're saying it may be better to focus on other things that decrease the risk of cesarean birth, as opposed to focusing on the financially and mentally and emotionally and physically draining process of induction. So I urge you to look a little deeper into the ARRIVE study, especially if you're pregnant and your provider is talking with you about induction at 39 weeks. Take a deeper look at this. See if the ARRIVE study kind of fits into your preferences. Ask your provider questions. Ask them what their protocol is for induction. Ask them how much time they give for an induction. Ask them what would limit the amount of time that they give for an induction. What kind of things could come up during that process that would then not allow them to give you 3 days for induction. And I did a post yesterday on some common comments that providers make about induction. And I followed it up with a blog post that kind of illustrates each comment a little bit more in depth in terms of what the research says and in terms of what people's options are. So I would suggest, if you do want to kind of dive a little deeper into this, that you check that out. The post is on Instagram at Blossoming Belly's Birth, and the blog is on the website at Blossoming Belly's Birth. There's a link to it in the bio in Instagram too. So if you want to dive a little deeper into common comments that providers make about induction and whether or not they are research-based, and what the research says about those specific scenarios, you can find that on there. And now, some acute clinical reasons, common acute clinical reasons, meaning there is a red flag that has come up that is now signaling there's a concern about this specific individual pregnancy, and induction may be the best way to move forward. These include high blood pressure, gestational diabetes, preeclampsia, and true diabetes. These are not the only reasons that exist. These are not the only acute clinical reasons for induction, but these are common acute clinical reasons for induction. I also want to point out that when it comes to induction, let me kind of come out of this for a second. When it comes to induction, it is always a gray area. There are absolutely situations where taking an evidence-based approach, it seems that it is the best way to move forward with induction. But it is also really important to keep in mind that it is a gray area. If it was a true emergency, a cesarean would be recommended because cesareans get babies out quickly. But if it is an induction that is being recommended, there is likely time to ask questions of your provider and come up with a plan together that makes sense. So let's come back now to the slides. That was some intense information there. So maybe you guys need to take a deep breath, focus on something, take a look out the window. We have a blue sky outside right now here, so that's really nice. Kind of recenter yourself. That was a lot of heavy information. So maybe roll your shoulders back a bit, roll out your neck a little bit, give yourself a moment to process, and then we can kind of come back together. So let's take a look at most common reasons for augmentation. So augmentation is when labor progress is not occurring at the rate that's desired by a provider and or set forth by policy guidelines. We could also say, though, that augmentation is when it's not occurring at the rate that an individual person, the birthing person, is comfortable with too. It could be a decision that you've made with your provider to augment laboring process. Or if it's suggested by a provider, you could feel like, yeah, I'm getting really exhausted. I need this to move along faster. Baby Center says Baby Center says that augmentation is helping along a labor that is not progressing as it should. This is why I really encourage people not to get their information from Baby Center, because that statement sets it up as this is how things should move and this is what's happening with your failed labor, quote unquote. So I think it's really, really important to not take statements like that at face value, because they can really kind of destroy our ability to look a little deeper into things. So it's not that a labor is not progressing as it should. It's just been decided either based on policy guidelines, the individual person's emotional and physical comfort, and or a provider, birthplace policies, and so forth, that labor is not necessarily moving forward as would be fitting into those preferences or policies. So what I encourage you is to be aware of the role that language plays in developing our fears and anxieties and in processing information. So that Baby Center statement, I think of that as a fear-based statement. It's saying, oh my gosh, like if your body doesn't work as it should, this is what's going to be suggested. When in fact, augmentation does not necessarily mean that things aren't moving along. It means that things aren't moving along at this desired rate. I would encourage you to seek out research-based resources other than Baby Center, other than what to expect when you're expecting.com. And not pregnancy.com or about pregnancy or whatever that website is. No, seek out research-based resources. These include evidence-based birth, Cochrane reviews, and studies from the National Institutes of Health and PubMed. Those are great resources for research-based information. I know birth professionals, you guys all know about evidence-based birth. Parents might not. If you're an expectant parent, check out Evidence-Based Birth's website. They have a great podcast too. They have such good information. And I'm not affiliated with Evidence-Based Birth. I'm just sharing this because they are really a fantastic resource. Their website is totally easy to navigate. Their podcasts are full of usable information. If you don't want to hear all the research that they talk about, you can go to the end and check out the conclusion section, which gives you a nice quick summary of what the research suggests. It is such a user-friendly website. It's intended for expectant parents and for birth professionals. I can't speak about it highly enough. Cochrane reviews are meta-analyses, which means that it is a group of medical professionals that have looked at several studies and come to conclusions based on the research in several studies. And they let you know whether that research is low quality, medium quality, or high quality. And then studies from the National Institutes of Health and PubMed are individual studies. So let's say you see a study on evidence-based birth and you're like, I want to read more about that study. Then you can look up that study on the National Institutes of Health or PubMed website. So those are some great resources to check out for evidence-based information. I would not suggest getting your evidence-based information from Baby Center or what to expect when you're expecting.com or places like that. So I just remind you guys, I know there's some action happening in the chat. I'm not seeing what action is going on in the chat, but I totally encourage you guys to type any questions you have into the chat, and we will leave a little bit of time at the end for talking about those. So when it comes to informed decision-making, here's what we want to focus on. We want to use evidence-based decision-making. We want to understand what our rights are in labor. And I would suggest checking out the Childbirth Connections, Every Laboring Person's Rights. I think they have it called Every Woman's Rights. But I have changed it to be Every Laboring Person's Rights. I think using inclusive language is really important. And I would also check out Birth Monopoly. They are an amazing research-based organization website that looks at people's rights in childbirth. I would also encourage you to have a conversation with your provider, and not at 38 weeks of pregnancy, 22 weeks, 24 weeks. Those are the times when you start asking questions of your provider. And I have heard so many what I think of as really negative experiences where providers say, oh, we'll talk about that later on. We'll talk about that when labor gets closer. No, you are the consumer, you are the client. You can say to your provider, this is important to me now, and I'd like to cover this at this point. The more information you have earlier on, the easier it will be to figure out if your birthplace matches up with your preferences. And then I urge you to become comfortable with refusal. This does not mean that you are going to negate everything that your provider is recommending. Even if your plan is not to refuse anything, becoming comfortable with refusal is a life skill. Becoming comfortable with refusal is something that you might need to do if you have a question and your question is not being addressed. Just like we said, if somebody's at 22 weeks of pregnancy, they ask a question of their provider and their provider says, no, we'll talk about that later. Becoming comfortable with refusal would mean, no, you become assertive and you say, I'd like to talk about this now. I have a webinar on the website called Advocacy in the Laboring Room. It's worth one contact hour too for any birth professionals that want to check it out, but it's also great for parents just to kind of understand a little bit more about how they can effectively communicate during the laboring process. Please remember there are always options. Your options include consenting and refusing, but you also have the option to delay, meaning let's wait a couple days and then we'll have this conversation again, or let's wait an hour and see how things play out. And you can also request. You can request certain medications, procedures, timeframes. You can also request cesarean birth. This is really important to know that you have the right to request intervention just as much as you have the right to refuse intervention. So remember, you always have options: consenting, refusing, delaying, or requesting. So in the limited time that we have left, geez, who knew we could talk about induction for so long? I just want to go over a few things here. There's a lot of information here. I encourage you to screenshot this. We're not going to go into each individual portion of the chart here, but I do want to point out the main ideas, which are the Bishop score, understanding cervical ripeners, and initiating or continuing progress. So when we're looking at in the induction process, we want to think about it in terms of this timeline. The Bishop score is an assessment of the readiness of the cervix for induction. The Bishop score assesses a point value to dilation of the cervix, effacement of the cervix, station of the baby, consistency of the cervix, and position of the cervix. And this is all specifically done prior to an induction. So this is if a provider is trying to determine whether an induction is likely to end in a vaginal birth or a cesarean. A provider will often request to assess the cervix and the station of the baby first, and this is called the Bishop score. If the score is less than 6, after you tally up all of those points, then the ripener is what the induction process is begun with. If someone scores 6 or higher, then it's often the induction process is often started with an IV of Pitocin. Pitocin is synthetic oxytocin. Oxytocin is the hormone your body naturally produces to encourage labor contractions, among other things. So with the ripeners, this is where the induction process begins if the Bishop score is less than 6. Ripeners include prostaglandins, including Cervidil and Prepidil, or misoprostol, which is often called Cytotec, which is a little pill, or a balloon catheter, which is actually a catheter that has a balloon on one end, and it goes inside the cervix. In order to have a balloon catheter done to initiate the laboring process, someone does have to be about close to 2 centimeters dilated. So we have these 3 different options to begin the laboring process with a ripener. Now, let's say we've undergone the ripening process and now it's time to continue the laboring process. that's when we would pick up with IV oxytocin or IV Pitocin. That's the brand name for oxytocin. Or if somebody's Bishop score was higher than 6, we might begin the induction process with the IV Pitocin. Generally speaking, and this is anecdotal, it seems that if the cervix itself is not yet 3 to 4 centimeters dilated, IV Pitocin does not seem to work as effectively for inducing labor. So again, taking a look at that Bishop score is important, but also thinking about how open the cervix is at that point. So when initiating or continuing progress with an induction, it is often IV Pitocin that is given, but it may also include artificially breaking the bag of waters, which we refer to as AROM, artificial rupturing of the membranes. And that would be done with an internal exam. AROM can be done just to initiate the laboring process, but there is an increased risk of infection when something goes inside the vagina and the water bag is broken. So quite often after IV Pitocin is hooked up, then if a provider is looking to do more intervention, they might then break the bag of waters. So you can see some of the research there. So if you want to screenshot this and use this for your own personal use, you're totally welcome to do that. I know earlier on I said don't take pictures of the slides. You can take a picture and obviously use it to dive deeper into this information. So let's take a look at these individual medications. So in terms of the cervical ripeners, this is done if the Bishop score is less than 6. This may also be done with a provider who assesses the cervix and the cervix is not yet 3 centimeters. The goal with the ripeners is to soften and open the cervix, which will either begin or further dilation and encourage contractions. So it's not just about opening the cervix, it's also about getting contractions going. The timeline for cervical ripeners differs depending on the ripening method. If misoprostol or Cytotec is given, it's given in 4-hour doses, usually requiring at least 2 doses to work. And it may be used with a balloon catheter inserted until that catheter comes out on its own or 12 hours have passed, in which case the catheter would be taken out. The catheter could be 2 different types. There's a Foley and there's a Cook. A Foley catheter, and you can Google this and see pictures of it, is a silicone catheter with a little balloon on the end. And the balloon is not inflated. It goes inside the cervix and then it's injected with saline. So this balloon that's filled with saline sits on the inside of the cervix, inside the uterus, and applies pressure on the cervix to start thinning it out, which we call effacement, and also to begin opening it up. A Cook catheter has a balloon on both the top and the bottom. And with a Cook catheter, both balloons are injected with saline, and so there's pressure from both the top and the bottom on the cervix. With the Cook catheter, research actually shows that it's not as effective as the Foley catheter, the one balloon. The Foley catheter actually has a shorter time between administration and it falling out on its own, and the Foley balloon actually shows a shorter length of labor as compared to using the Cook balloon. So if a provider gives you a choice, the Foley balloon is what research suggests. If someone is given prostaglandins like Cervidil or Prepidil, Cervidil is like a little tea bag that goes inside the vagina up by the cervix, has some prostaglandins or hormones in it, synthetic hormones, and that tea bag is replaced, not really a tea bag, that little bag is replaced every 12 hours. It has a string attached to it, just like a tampon. The benefit of the prostaglandins usually Cervidil, that little tea bag-like thing. The benefit of the Cervidil is that it can be pulled out. So as you'll see, one of the risks is that contractions can get too intense. If that occurs, you can pull the Cervidil out. With the misoprostol, also called Cytotec or referred to as miso, it's a tiny little portion of a pill that's either taken vaginally or orally, and it dissolves, meaning that if those contractions get too intense, there's no way to get it out of the body. That's the downside of miso as compared to the prostaglandins. The benefit of miso over prostaglandins would be that the miso is given every 4 hours, the prostaglandins are given every 12 hours, which means potentially less time in the hospital with miso as compared to with the prostaglandins. So from a time management standpoint, both from a hospital perspective and from the perspective of the person laboring, miso is beneficial. From a concern over hyperstimulation of the uterus, we see that potentially the prostaglandins are better. And the research really does not show whether one is more effective than the other at this point. To achieve progress, sometimes the different methods of ripening are interchanged with one another. So someone starts out with a couple of doses of miso and then may also wind up getting the Cervidil or the prostaglandin tea bag. And again, like we said, it may also include the use of the Foley balloon as well. And then in terms of the induction, or the, I'm sorry, the, we're talking about induction, continuing of labor. The idea is that after the cervix is now ripe and dilated and thinned out, the goal would be to encourage consistent contractions that continue to create change in the cervix. And this generally means increasing the use of IV oxytocin or Pitocin until contractions are about 2 to 3 minutes apart. If contractions at 2 to 3 minutes apart are causing concerns about the baby, they can turn the Pitocin down or off. And then the baby is within about 10 to 15 minutes is potentially able to have their heart rate recover. And then they could restart Pitocin at a lower dose. I think there is this myth out there that if Pitocin causes the baby's heart rate to dip, then the baby's in distress and immediately someone goes in for a cesarean. And that's not the way that it usually works. Those contractions are squeezing the baby, which decreases the baby's reserves of oxygen as the baby uses those reserves up. But if the Pitocin contractions are causing a concern with the baby's heart rate, the Pitocin will be turned off or turned down, and the baby will be given a chance to recover before it's decided to move along with a cesarean. The Pitocin could be turned off or turned down, and then after an hour, possibly 2 hours, restarted at a lower dose. The idea is that some degree of cervical change is expected within 4 hours. So every 4 hours, that's what ACOG is kind of looking at in terms of there should be something happening. If it's a centimeter of change, that's awesome. If it's 3 centimeters of change, that's awesome. If it's more significant thinning of the cervix or the baby moving down, that's awesome. That all counts as progress. As we mentioned before, artificial rupturing of the membranes may also be recommended as part of the process. So to achieve progress, generally, providers will do the Pitocin, administer Pitocin. They may decide to break the bag of waters. Again, this is a conversation you can have with your provider about risk versus benefit. And then generally, they wait up to 2 hours to see whether progress has continued or not. Pitocin may be increased anywhere between every 15 to 60 minutes. And like we mentioned, it can be adjusted if not tolerated, they're not tolerating it. So what's important to remember with the Pitocin adjustment is that you have a say in this. You have a say in terms of how quickly that Pitocin is increased. If your plan is to labor without pain medication, perhaps you request that the Pitocin be turned up at a slower dose. If your plan is to just limit your interventions as much as possible or be very judicial about the decisions that you're making, then possibly you request that the Pitocin be turned up every 60 minutes or so. You know, you kind of can work with your provider in terms of how quickly they are encouraging that induction process. The risks involved with administering IV Pitocin include greater likelihood of requesting pain medication. Contractions are stronger, they're longer, they're closer. The baseline tension in the uterus is higher. So going back to individual preferences, if someone's preference is to labor without pain medication, recognizing that induction may increase the likelihood of requesting pain medication is an important consideration to take into account. There is a greater likelihood of distress in the baby, and this is not because the Pitocin itself causes distress, but because the contractions caused by the Pitocin can lead to distress. And then administering Pitocin throughout the laboring process increases the risk of excessive postpartum bleeding down the road. So we're talking 24 hours, 48 hours after birth. So if you have had Pitocin during your labor, making sure that you're really mindful of monitoring that postpartum bleeding, particularly after leaving the hospital, is really important. So this is a lot of information. This is why the recording is great, because you can go back and rewatch certain parts if you need to. The takeaway for all this is that the decision to induce is ideally a decision made between the client and their care provider after taking an evidence-based approach, which means weighing out the research, the client's preferences, and the trusted care provider's recommendation. Birthing people may have more choices than they realize when it comes to decision-making, when it comes to methodology, and when it comes to the induction timeframe. You have a say every single step of the way. And again, if you check out that induction blog post that I wrote, there is a graphic there on the questions that you can ask to make sure you get as much information as possible. So definitely check out that blog post. I will include it. If I haven't already, I think it's in there. Let me write this down. I'll put a link in the bio. I think it is in there actually. A link in the bio to a link in the bio of my Instagram, which is Blossoming Belly's Birth, to that blog post. So you can check it out on there. And remember, knowing one's options and maintaining one's voice in the decision-making process leads to emotionally healthier birth outcomes, which impacts well-being into the postpartum. This is why understanding your options, your rights, effective communication is really important because it does affect your postpartum experience. Research shows that the involvement of someone in the decision-making process throughout their labor impacts how they look back on their birth, which impacts their well-being into the postpartum. So thank you guys for joining me for all of this intense information. Let me check out the chat here. We have a lot of great stuff going on in there. I saw that little button lighting up. Let me see here if we have a couple questions. I know we are just at time, but I want to make sure that I answer any questions that seem to be relevant for a lot of people. Cool, lots of people sharing. Yes, somebody told me I can mute everyone. Thank you. I figured that out a little too late, but now I know for next time. Let's see. Let's see. Lots of great. Yeah, there's a question. Aren't you prone to infection once your water breaks? I think waiting 3 days would increase risk of infection. And then further intervention. Great question. So what the research actually shows is it's not the water breaking that increases risk of infection. It's something going inside the vagina when the water breaks or at some point after the water has broken. So we don't see an increased risk of infection until something has gone inside the vagina when the water is broken, which is why when a provider artificially breaks the bag of waters, yes, that will increase the risk of infection generally within 24 hours. And we see a jump in that risk for infection every time something goes inside the vagina. So we do see increased risk of infection once the water is broken, but not until something goes inside the vagina. So that's a great thing to point out. Let's see. So this is something that is covered in the evidence-based birth article regarding a big baby affecting how the pregnancy and labor progresses. The question is, does that mean psychologically, like it messes with your head? That's a great question. Yes, and it could on the part of the laboring person, but we're talking about a provider's approach. A provider thinks the baby is big, so a provider recommends more intervention. That's how that plays out. And you can read more about that in the evidence-based birth article on big babies. Let's see, amniotic fluid will continue to be produced until the baby's born. So baby does not dry up in there. Let's see, evidence-based birth is awesome. How can I learn about my hospital or practice's policy on things like failed induction? This is a fantastic question. And I know we're at time now, but I would love it if you guys want to hang out for a few minutes and just, kind of sort through some of these questions. If you have to go, that's also fine. You can always watch the recording later. But this is a great question. How can I learn about my hospital or practice's policies on things like failed induction? The Birth Hour, which is a website, has a fantastic article on questions to ask when choosing a care provider. If you have already chosen a care provider, I would still bring these questions to your care provider and ask them, because these are questions that will help you get a much clearer idea as to what the policies are and the typical practices are at your place of birth and with your care provider. Here's the thing though, it'd be really awesome if every provider said, here is a list of our policies and handed you a 10-page packet that literally laid out everything. If only it was that easy. It's not. And one of the reasons for this is that policies are subject to change, especially as we know with all the COVID restrictions that have come and gone and come back again. But it's also because there is leeway, there's wiggle room for providers with policies. Just because a policy is in place doesn't mean that every provider in every situation is necessarily going to adhere to that. So what I would suggest is check out thebirthhour.com. They have I think it's .com, maybe .org. But the Birth Hour has a really great article on their website about questions to ask when choosing an OB. And it is questions that are totally usable if you've already chosen your provider. And bring that to a prenatal visit. This is a great example of what we were talking about before. 20 weeks of pregnancy, you bring this to your provider and say, I have some questions for you. And if the provider says, well, I don't have time for all these questions, I need you to make time for my questions because this is important to me right now. If a provider says, oh, we'll talk about induction down the road. If you haven't gone into labor by, the end of pregnancy, we'll talk about it then. No way, because you want to know what those policies are ahead of time, especially if it will impact the choices that you make moving forward. So I would suggest checking out those questions, compiling a list, maybe bringing 5 or 10 questions that are important to you to each prenatal visit. Providers will often ask at prenatal visits, do you have any questions? And if we don't have them written down, it's like, well, maybe I don't remember. And then they're like, okay, great, see you in 4 weeks. And that can be really stressful. And then you leave and you're like, oh my gosh, I did have all these questions. Write them down, literally have it in your hand. I would even say a piece of paper, because if you have your phone in your hand and your questions are in your phone, it's not the same thing. We're used to having our phone in our hand, right? So we might not even think, oh yeah, my questions are in there. So instead, have a piece of paper in your hand. We're not so used to having pieces of paper in our hands anymore. You have this piece of paper in your hand, you know that it's there, you know that you have these questions to ask of your provider. So that's a really fantastic question. Thank you for that one. Let's see. So in terms of gestational diabetes, I would definitely suggest checking out the article at Evidence-Based Birth on gestational diabetes in pregnancy, because there's a lot of conflicting information out there, but then there's also some very clear recommendations. So when it comes to gestational diabetes, I would check out the Evidence-Based Birth article on induction for gestational diabetes and read through that and kind of sort through that information as it relates to your particular pregnancy. Oh, thank you. Induced. Yeah. So I don't understand why I'd have to be induced if I'm controlling my sugars with diet. Take a look at the research, take into account your personal preferences, and then make a decision that feels right to you. Again, for some people, they're going to be like, yeah, I'm definitely going to induce 39 weeks. And for other people, they might feel comfortable saying, I'm not going to induce right now. I'm going to wait for spontaneous labor. Take a look at the research, figure out how it fits into your preferences, and make a decision that feels right to you. It's not a one size fits all by any means. Let's see. Yeah. Oh, shit. This person's saying that their provider told them not to worry about certain things. This person felt dismissed and left their provider and went to another provider. Yeah. Let's see. Lots of gestational diabetes questions. Great. Yeah, the gestational diabetes podcast on evidence-based birth is also awesome. Oh, here's a good question, totally relevant to what we were talking about with cervical ripeners. And I didn't mention this, and I appreciate this being asked. Is cervical ripening performed at the hospital? It seems like a long process to go through before allowing for 24 hours of Pitocin. My hospital doesn't allow me to eat solids once admitted, so I can be starved into wanting a cesarean after all this. Really important, such important information, or such an important question. And I love the little connection that you made there to staying nourished through labor. So yes, the cervical ripening process can be lengthy. It could easily be 24 to 48 hours on its own. And that process does happen in the hospital. Consistent monitoring is typically happening as well, although you can get off the monitor to go to the bathroom. Possibly if the baby's looking good, if you wanted to take a quick shower or something like that, you can do that. You can move around. But yeah, you're in the hospital during that entire ripening process. The hospital policy of no food, which is a common hospital policy, that would count within an induction as well, but usually during the ripening phase of the induction, providers do quote unquote let you eat. But let me also tell you this, that the research supports eating and drinking freely in labor. So even if your hospital policy does not reflect the most current research, recognize that the research does state that you can eat and drink freely in labor. Staying hydrated through labor can actually shorten the laboring process. And as you can imagine, you're going to be hungry if you're there for 2 days straight, and your baby needs those calories too. So if you feel comfortable eating in labor, whether it is going along with hospital policy or not, of course, you can totally feed your body. You have the right to feed yourself regardless of what hospital policy says. And you can kind of look more, again, like I urge you to kind of dive a little deeper into the research behind eating and drinking in labor. But it is shown to be safe to eat and drink in labor freely, even if someone has pain medication and during an induction process. So you can totally talk with your provider about what the research says, and then say to your provider, this doesn't seem to match up with hospital policy. What are your thoughts? And then you can make a decision that feels right to you in labor for your individual circumstances. Yeah, misoprostol is not FDA approved for use in labor. Yes, Amy said that, and that is correct. Misoprostol, the miso that we were talking about, also referred to as Cytotec, is not FDA approved for use in labor. Misoprostol is an ulcer medication, and they found that when they gave it to pregnant people, it caused them to go into labor. It is also a drug commonly used for abortions. Misoprostol is not approved and will never be approved by the FDA because it does have a history of uterine rupture. However, That's when it's given in 100 microgram tablets, which are the tiny little pills that it's made, the size that it's made in. When a provider gives misoprostol in labor, they give 25 micrograms at a time. There's this loophole that the FDA has that if a drug has been approved for one purpose, at a physician's discretion, it can be used for another purpose. There are some hospitals in the area that do not use, not in the area, in the country, that do not use misoprostol at all. In the Philadelphia area, a lot of hospitals, in fact, all the hospitals offer misoprostol. And there are some hospitals that prefer the use of misoprostol over other ripeners like Cervidil. So yeah, absolutely right. It's not FDA approved. However, there's this little loophole that allows it to still be used in labor. Let's see. So risks with AROM, risks with artificial rupturing of the membrane. So there is a risk of infection within 24 hours. The risk for infection if you are GBS positive happens within 18 hours. Other risks with artificial rupturing of the membranes is that if the baby is not ideally positioned for your body, like let's say, for example, the baby has their hand up by their head and maybe their head is tilted. If the bag of waters, that cushioning around the baby's head is no longer there, then the baby kind of surges down into the pelvis a little bit lower with the release of that cushioning, and the baby may be more likely to stay malpositioned in the pelvis, which can decrease the likelihood of labor continuing to progress. So that is definitely a concern. There used to be a time clock placed on laboring once the water bag was broken because of that risk of infection. But what the research suggests is that monitoring someone's labor more closely, as opposed to saying, you hit the 24-hour mark, let's do a C-section, is actually what's more ideal. So the big concerns that we see with AROM are increased risk of infection, and then potentially kind of wedging the baby in the pelvis by having the baby lose that cushioning around their head. Great question. Let's see. Yes, thank you for posting the link. That's awesome. Thank you for posting the link to the blog that has the induction stuff, the induction blog post on there. Let's see. Yeah, so Courtney is asking about induction after an ECV for a transverse lie. That's a really interesting question. Courtney, if you want to just send that to me in an email, we can talk more specifically about that scenario, because I think that's really interesting. Yeah, so I encourage you to just email me. That kind of gets more into my pelvic related, fetal positioning related stuff. So if you want to send me an email on that, we can chat more privately about it. Demand they answer your questions. If they can't answer during the visit, I've called the nurses line after. Yeah, totally. Be assertive. You know, this is your birth. So important. Your providers, they catch babies all day, every day, which is amazing and totally awesome. But for them, it's just another birth. You know, for you, like, this is your birth. Whether we do this once in our lives, whether we do this 5 times in our lives, these are really special moments that we are going to carry with us through our entire lives. So be assertive, ask the questions, get the information. You're also paying them to be there for you. Whether it's your insurance that's paying or not, you are paying your provider. You are the consumer. And consumers drive change. If you demand more from your provider, more information, more time, that can make a really big difference. And also, it can really give you an insight into how supportive providers are going to be during the laboring process too. The earlier you start asking questions, the more clearly you will understand what you may need to advocate more strongly for in labor, and the better you can prepare yourself for that advocacy. And the more you may realize this provider doesn't fit with what I need, maybe I should seek out other options. If we don't start asking questions until 36, 37 weeks of pregnancy, we're often in a position where we feel stuck. And although it's never too late to change providers, spending the last month of your pregnancy trying to find a new provider is not a stress-free task by any means. So be assertive, absolutely. Ask these questions, make sure that your provider is answering them. And I love this, that if they can't answer during the visit, you've called the nurses line. That's awesome. Yes, demand that your questions be answered. So this has been really great. Thank you guys so much for joining me. Thank you for hanging out 15 minutes later. I feel like we should have made this webinar 2 hours. Maybe we'll do part 2 in a couple months. If anybody has ideas that they want for more free webinars coming up, send me an email. My email, I'll put it in the chat. It's brit@blossomingbelliesbirth.com. I do these free webinars roughly every 6 weeks or so. I'm always looking for more ideas. I want to hear what you guys want to know about. So please feel free to send me an email and let me know what you want to hear. Also, if you're interested in checking out what we have online available that's already recorded, you can go to For Parents or For Birth Professionals, depending on what category you fall into. That's at Blossoming Belly's Birth. And you can scroll down to webinars and you can see all the different options that we have, both free webinars and then $15 webinars that are on there on all sorts of different topics. You can register for what we have coming up in the future. And also, if you're a birth professional and want to join me for the pelvic dynamics workshop in April, it's a full day workshop with 6 CEs from ACNM. I would love to have you. So thank you guys so much. I really appreciate all the time and the energy and the listening and the absorbing that you put into this. And I hope you all have a really wonderful day. And hopefully I will see you again at another webinar or workshop in the future. Take care, guys. Bye.